Hello, everyone. The last session of the day. Well done. I will start by thanking our sponsor, Lake Imaging, for sponsoring this session. And second thing, remember that everything that's in these talks links back to health pathways. And so what we hear today will be, it'll be on health pathways, so it's a great resource to use. So I want to welcome two of our very famous GPs in our region, in Geelong region, Dr. Rick Milner. I'll start with him. I think he's well known to most of us, and he is I think he's not doing some of these things now, but he's been very involved in lots of things in Geelong, involved in the Hep C treatment centre. He founded the Bowen Health Sexual Health Clinic, and I think through a lot of these things, he's developed an interest in opioid problems, and it is something that we all struggle with. So I think this is a great talk that we'll all be interested in. Yeah, I'll finish with that. If we can move over to Cameron Loy. And Cameron Loy, again, does lots of different things. He's a GP in Lara, and he's been in Geelong since 2004. He is former Royal Australian College of GPs on the board. I think he's no longer doing that. And again, he is an opioid replacement therapist. So, and he works a lot with opioid issues. So we welcome both our speakers who are going to be talking about strategy for prevention with opioids problems. Thank you.
Thank you, Anne. So we'll get straight into it. We're both taking our masks off because we're drinking water. So cheers. This talk is based on our experience of many years of dealing with people who have unfortunate opioid problems, and we will start with a bit of background and some public health stuff, and then some cases. Because we like cases. So
if we just hold on to the next one here, opium has a really long history in our civilization, going back thousands of years. The two quotes there I thought were really interesting. This is like the second book of our Western civilization, Homer's Odyssey, as everyone comes back from the sacking of Troy. And there are two times during that book where there is some debate as to whether or not the substance that is being given to either the sailors or Helen giving it to the troops was actually opium. One was called nepenthe, which is probably opium, and the other is when they landed on the island of the lotus plant eaters, and that was also probably opium that they were doing. Nepenthe was sort of loosely translated as that which chases away sorrow. The picture on the other side of the screen, this is an old Neolithic site where they've found poppy seeds surrounding some burial sites and some presumed religious sites. The place is called the Cave of Bats. It's north of Malaga in Spain, Cueva de los Murciélagos. In other civilizations, in Sumer, opium was called hulgil, which was loosely translated as the joy plant. And the reason why we've got this slide up is just to point out that for a lot of the history of humans, opium wasn't so much used for pain as it was used to dissociate. So Helen was using it to help the troops dissociate, probably presumably from their war trauma. And the sailors were using it on Lotus Island to try and escape the trauma of being at sea for all of those years. And click next one. And I guess that's where it comes into modern era. Now, this is a really interesting story, and why I wanted to include. I'm not sure Rick was particularly keen, but it's there's a very little known part of Civil War, US Civil War history that saw the first time that morphine was used extensively during for pain during conflict. So it was there was often mixtures of gin given to soldiers before they had their legs and arms cut off after being injured. The Union Army used something like 2,000 syringes and had 80 tons worth of opium handed out to troops. That's about 10 million pills, which is really kind of remarkable. There's a little song that came from, which is probably a little bit loud in your speakers at the moment. And we can't, can you control the bottom?
No, control.
So it's estimated that there are about 200,000 opioid. Actually, do you want to see if you can turn that sound down?
Yep.
Go backwards. This is just our.
That's it. It's down.
That's all right. We'll get rid of that noise because it's actually too loud. There's estimated that there was 200,000 opioid-dependent veterans that came back from that war, and that sort of a violin ditty that was being played in the background there that was way too loud, my apologies, was actually about a soldier that had lost a limb during the Civil War and was craving just having more heroin to try and escape. And it's not long afterwards, in 1888, 15% of all of the prescriptions that were given in Boston were actually of opium. And even, I guess, given that Hamilton is now playing in Sydney, that we, of course, can't go to at the moment, after his duel with Aaron Burr, he was given an elixir of opium and alcohol as he died. So addiction appeared really fast after the widespread use of opium. Let's move on. You can do this bit.
And get it to work. Yep.
Click.
What happened there?
We've just jumped out.
Have we?
Yep. We've completely bombed out of the screen.
I clicked. We can't. We've got to click this one out, do we?
I have no idea.
Are we still in here?
No.
Okay, here. Can you see us?
So we don't know what. Yeah,
Okay.
so we don't know what's. Are we being seen in the main screen?
Okay.
Okay, because we can't see that. Okay, just continue. That's it.
Okay.
You go.
So what happened? In the late 20th century, about 1990s, there was a pressure because people were dying uncomfortably with serious disease like terminal malignancies, and there was pressure to treat pain better. And then after that, things went astray. So we play this one. Can't hear it?
We can't hear. No, we can't hear that. I don't know whether it's because of your headphones. Maybe that if you both take your headphones out,
yep,
that may work. I'm not sure.
Can you hear it now?
No.
Okay.
What about you take your?
They're out.
They're out. They're out.
Okay, well, we can say what he says.
Yeah.
Basically, what he says was that there was pressure put on to, appropriate pressure put onto doctors who had what they called opiophobia, which is that doctors were terrified of creating addiction, and they would not prescribe opioids for people with terminal pain or even post-surgically. So there was a movement to train doctors to do better, which then worked. But then there was a sort of almost a human rights argument that if you are providing good pain control for people who are going to die or who have post-surgical pain or acute pain, why not do the same thing for people with chronic pain? There was not a lot of data about that. So there were some small studies done, not many. And not many of them were very long. None of them were more than 12 months.
And we're going to get to one of those in a second. Yeah.
Okay, so we'll move on.
So move on to the next slide.
If I can.
I'm not going to press any button. There it is. No, it appeared on the screen. There it is. Good. So click.
Yeah.
So press it, because at least the images will come up.
Okay. So this, you can say this.
Yeah, so this is when there was this push for, from particularly one of the pharmaceutical companies, that tried to incorporate this idea of the fifth vital sign. And it was around this idea that, pain builds character. Infants actually do feel pain. But the last one was interesting. The last one's interesting there. That's why we had that up there. That amongst all of that human rights argument that Rick was just mentioning, they crept in this idea that painkillers are not addictive. And that seems contrary to probably a couple of hundred years of experience with the drugs. But nevertheless, it was a very pervasive story. So let's go to the next one. That's all right.
So it's the same thing, but more so.
Click in. That's it.
So this letter is much quoted. And this was a very small study of people with acute pain. And basically this letter says that in this a letter, it's not even a study, that I think it was 1% of people became addicted and who were given opioids.
So it's a massive nonsense in that this particular letter is one of the most quoted articles, letters that appears in this set of literature. And it really isn't relevant to anything that subsequently happened.
So then this occurred. So this, we'll get this to play. You won't hear it, unfortunately. But we've actually heard, or I have heard this line that this guy's saying from people in the late 90s, early 2000s. And the view then was that if you had someone who was had pain and they were requiring bigger and bigger doses of opioids, and even if they had a past history of heavy illicit use of opioids, that meant that the reason they were seeking opioids was because they had undertreated pain. And they called this pseudoaddiction. Now,
we were hearing that right up until sort of the mid part of the last decade, so 2005, late 2000s, where we were having education sessions, really, where some very prominent people were standing in front of us saying, if you've got a patient with chronic pain who is using heroin, they have undertreated pain, much to the dismay of the 3 or 4 people in the room that were fairly familiar with prescribing buprenorphine and methadone at that stage. So, it was just so convenient in that we knew that there was some addiction problems that appeared really early after the use of these substances, that this marketing drive to increase the amount of prescriptions of OxyContin and opioids, oxycodone and opioids. And then when addiction did reveal itself, it's like, no, it's pseudo addiction. It's not real addiction, which is remarkably convenient, which is why you're seeing John Oliver paused in the screen there in his usual indignation.
Okay. So why should we bother reducing opioids? They've been around for decades, and I'm convinced they will be around for decades, and they're quite useful drugs. Have this talk, and part of the reason is they're pretty dangerous. So as the slide says, in this area, in this region alone, there are more opioid deaths than car accident deaths. There's also some evidence of a lot of evidence of increased deaths. The rate goes up with higher doses, and that a lot of them are accidental. They're not suicides, they're accidental overdoses. And I would suspect, and the coroner in 2016 mentioned this, that some of the car accident deaths, particularly on country roads, may in fact have a considerable or some input from opioids and other drugs.
And then we're going to get to that last point there, which is an interesting point that I think we've all seen, where people that are on high doses of opioids tend to actually feel pain more than if they weren't on opioids.
Yeah, I remember when I had treating a lot of people with methadone, and I had this uneducated view that they were somehow sort of soft, because some of them would complain to me when they put the blood pressure cuff on about how much it hurt, or they would complain that when they combed their hair, their scalp hurt. And this is a well-recognised syndrome of people with higher doses of opioids.
So let's go into all of these four in a bit more detail. You do this one.
Okay.
You've frozen,
right.
but they're back. You froze for a minute.
Oh, sorry. Okay. So we're going to go into those 4 points in a little bit more detail. Apologies for the technology. We're clearly having a few problems today.
So as I said, the coroner has clearly stated that there are more prescription overdose deaths than the road toll. There are more prescription overdose deaths than injected heroin overdose deaths. In New Orleans, in 2016, I mean, this is the States, it's a weird place, but more than murders, which they found quite shocking. Murders, I suppose, are acceptable. And in the States, in New Orleans, there were a huge increase in the number of neonatal opioid withdrawal syndromes, 8 per 1,000 compared with 1.5.
So that's the public health story, isn't it?
That is the public health story. But we're not as, and there's also, this is the public health story.
So this should actually scare a lot of us, I would say. If you look at these three studies, so these three studies, they were good quality studies, reproducible studies. 2 of them Veterans Affairs studies in the United States. And they were looking for the dose-related opioid overdose risk. And what you'll see there is once the dose of opioids gets above 50 milligrams of morphine equivalent. So Rick, just remind me again, what's the morphine equivalent of OxyContin?
It's 1.5. So to multiply whatever the dose of OxyContin is by 1.5.
So that works out not much, doesn't it?
That's not much.
So if you were on 20 milligrams, or you had patients on 20 milligrams of oxycodone long-release BD, that in itself equals 60 milligrams of morphine equivalent. So what you see in this chart is that once you get above that 50 milligrams of morphine equivalent, you start to see a disturbing trend of sudden and unexpected overdose deaths. Now, this wasn't people that were intentionally hurting themselves, admixing huge amounts of other pharmaceuticals. There is something going on here that I don't actually think we fully understand. The bit that I think really gets me is that you'll all be aware that we can use SafeScript to monitor the prescriptions that we are prescribing. But once we get to 100 milligrams of morphine equivalents, there is a requirement for us to actually get a permit and get a review from pain services and other hospital specialist service. I'm actually inclined to think that the problem's emerging at a far, far lower dose than that. And I think this is prompting, I think, us all to rethink what we mean by high and low dose opiate prescribing. Would you agree with that, Rick?
Yeah, I would. And I've shifted in that view. I used to think that with methadone, for instance, we had patients who are on 130 milligrams of methadone, and there's no reason for that. In that situation, they had evidence, particularly if they had other drugs like tricyclics, they had a high sudden death rate, presumably from arrhythmias. So they're dangerous stuff, and we had to wind it back. And when we wound it back to a maximum of 100 milligrams, their behavioural problems and their addiction problems were no different. So there was no point.
And I wonder whether there is much of a difference in effect between 50 and 100 milligrams in any event. I mean, you've always been an advocate for that.
Yeah.
That you know, almost no matter what drug you use and no matter what dose you prescribe, if you have 100 points of pain, you're probably only ever going to reduce 10 to 15 points of that through the use of opiates in whatever form, whatever dose.
Okay.
Look, this is a really interesting story, because I remember when Heath Ledger died, and there was a lot of stories about perhaps he committed suicide, perhaps he got too invested in his role in the Joker. In actual fact, most of that was just rubbish. Heath Ledger's dad, Kim Ledger, was the patron of sort of an opioid risk advocacy group called Scriptwise for many years, and he used to give a lot of talks about what actually happened to his son. And he's very firmly of the view that he did not kill himself. In fact, he had a serious audition the next day for a Steven Spielberg film. He was actually going to be playing Tom Hayden in a Chicago 7 film, and I don't know if you've actually seen it, but that role ended up going to Eddie Redmayne in a recent production of it. So that would have made Heath Ledger an absolute A-lister actor. And he wanted to make sure that he had some decent sleep, he had some pain from some old injuries, and had a pile of medication in his cabinet that, as we all know, various different types of the same class of medication with various different trade names of the same generic drug. And when the coroner released his toxicology, he had 6 drugs in his system. He had oxycodone, hydrocodone, diazepam, temazepam, alprazolam, and doxylamine. Heath Ledger's dad is of the view that his son just made a mistake. He just stuffed up. And that's what caused his death. I mean, who am I to say whether he's right or wrong? I mean, that's their truth and their story. But this is what we are actually seeing now. Accidental overdose is well and truly in the top 10 causes of death in Australia. And in the US, if you are a white middle-class woman in the suburbs, accidental overdose is the 3rd most common cause for you to die. And that's behind heart disease and cancer. Now, that story is one that we're all kind of familiar with. But when we sit and think through that, it is really quite striking and alarming.
And I also think the coroner in Victoria pointed out that the single best predictor of whether you're likely to have a opioid overdose death is if you are taking it with benzodiazepines. So benzos, I mean, understand how that might happen. You've taken your oxycodone and some benzos, you forgot you've taken it, so you take some more. And if you just tip over and you have a glass of wine, you can die.
So that's why we get that alert when you see safe scripts. When you get one of those red marks and they're alerting you that perhaps a patient has actually been prescribed benzodiazepines as well. Let's move on.
Yeah. Let's move on. Never. We won't look at
I included this slide in actually just to annoy everybody, really, because we get these slides in all of our talks and they're just bonkers. But really, the only message from that is it's probably a glial cell inflammation, and you see it with all the opioids.
Yeah. And I think the evidence for that is poor. I think it's much better to say we don't know why opioid hyperalgesia occurs, because I don't understand it, why it occurs, but it's no doubt it occurs. And it's only treatable by reduction of the opioid.
So should we do some cases before we run out of time?
Yep. What are we up to? Yeah, we're getting there.
So we've got 3 cases, and we just want to talk through them because they're entertaining, and there's some fairly sort of striking, amusing stuff in a couple of them. But they do drive home some of the points about the traps and the holes that we can get into. So do you know, actually you talk about this one.
Well, this is known as a script of death, and this is a patient that Cameron had more to do with than me, but I did see this person. And this is the discharge summary after coming out of a tertiary teaching hospital.
So he walked out of a major capital centre, not in Victoria, a major capital centre teaching hospital with all of those drugs in a brown paper bag.
And the history of how he got those drugs, if you read the actual discharge summary, it was seen by the neurologists, the surgeons, the anaesthetists, the general physicians, the gastroenterologists, and every person who saw him added something. No one took anything away.
Yep.
They just added. He was complaining of more pain, more this, more that, and everything was just wound up and wound up.
Have you ever prescribed clonidine in the community, Rick?
For blood pressure? 100 years ago, but no,
yeah,
I haven't.
And so you can see this pattern in that where they just kept on adding. So you've got a couple of different benzos, ketamine lozenges, for God's sake, methadone, oxycodone, tramadol, Lyrica, carbamazepine. You know, it's I'd almost argue that there's not much missing apart from maybe fentanyl patches.
But when Cameron said to this fellow, God, if you took all that, you'd die. What did he say?
Well, he actually said that he made a bit of money out of it. In particular, the ketamine lozenges, apparently he said they were worth a fair bit of money.
So in approaching this person, if just talking to him and listening to his history, he clearly had huge problems with addiction. And as I said to him at the time, unfortunately, in terms of wrecking your life, addiction trumps pain.
And I think that's one of the important points here. If you've got a patient who's on a lot of opioids and complaining about a pain syndrome, it's really hard, and I would actually argue almost impossible, to determine what the pain syndrome is, because the addiction is just sitting there in front of it, obscuring it. And that's the thing that needs to be managed. So what do you think the priorities are for this one, Rick? Seeing we can't ask the audience.
Yeah, well, what I would do is always remove the benzos first.
I agree.
And the reason for that is people can't follow the process. So when you're trying to explain to someone the rationale for what you're trying to do, then I would get rid of the benzos straight away. I don't think the clonidines of any value. It's got some risks, so I would get rid of that. I hate tramadol. I think it's a dirty, useless drug. If you're going to, in my view, if you're going to use an opioid, use a proper one.
So you actually said something really interesting when you were talking about this background of this guy. You said that there was so much about him that made you think that he was dependent on opioids. What does that thought mean that you have to do?
That means I have to report this to the Victorian government.
Notification of a drug-dependent person.
I have to notify him, yeah, which has a whole lot of consequences.
Yeah.
Which means I can't prescribe him oxycodone.
Without a permit.
Without a permit, that's right. So what I would have done with this person, and what we both did do, he wound up completely off everything but methadone, and his methadone syrup, not methadone tablets. So we got him to understand that his problem was addiction. We got rid of all the rest. He was on, I think, 80 milligrams of methadone syrup daily,
and he was fine.
He was good.
In actual fact, his head cleared. He was thinking a little bit clearer. He was engaging in healthcare a little bit better. So I mean, I think the important points there is that once you've suspected or got a reasonable suspicion that somebody's a drug-dependent person, you're actually obliged to make a notification of a drug-dependent person. Under Section 34 of the Drugs, Poisons and Controlled Substances Act, there's a whole lot of obligations that you are then faced with. You cannot prescribe an opioid without a permit. And ideally, and in almost all circumstances, that is going to need to be an opiate replacement therapy, methadone, buprenorphine, or buprenorphine plus naloxone or Suboxone. And that's actually that person's option.
The difficulty is that if he is on a healthcare card, he could get oxycodone capsules for a month for $6.
And that's insane, isn't it?
But for methadone, he's going to have to pay between $5 and $7
per day.
And that is completely unreasonable and makes our life more difficult and needs to be fixed. I've been only saying that for about 20 years.
And that is the difficulty. For a patient to be on methadone syrup actually works out more expensive, sadly, than if they secured some of these medications on PBS scripts. But we are still obliged to go down these pathways. I mean, I think that is an important message of this.
Yep. You can talk about this one.
Okay, this is a man that I actually knew pretty well. He had a history of substance use, been on and off opiate replacement, hepatitis C, hepatitis B, both contracted from injecting drug use. He was an extraordinarily overweight man with a very large abdominal apron, a very deep lumbar lordosis that I used to say you could actually position a cup of water on his lower back and it wouldn't actually fall over. He also could not activate, if his life depended on it, he could not activate any of his core muscles. As part of trying to manage this, he ended up in a secondary service. And this was the response that we got back. His current medication is 80 milligrams, 12 hourly of MS Contin. I would suggest that you slowly titrate this over the next 3 to 4 weeks to a maximum dose of 320 milligrams per day, given as 2 divided doses. Do you think we did that, Rick?
We did not do that. We got him to see the physio. We started getting exercise stuff. There was nothing from this opinion about activity, and we didn't do any of those things. And he objected, but he did okay.
I'm also convinced he didn't really have sciatica. I mean, I don't think his description was actually paresthesia in his legs. But really interesting, if you go back, and I don't know how many of you have ever looked at this, if you open up the product information for one of these drugs, there is a truly unusual entry about dosing that talks about these massive increases in opioids that I've got to say in 2021, not one of us should be doing.
Okay, so this is a more commonplace problem, and this is where I think we get into difficulty. So this is a 72-year-old woman with OA hip waiting for a hip replacement and lots of pain. And she's had recent intra-articular steroids, which did nothing apart when the local anaesthetic wore off, didn't make any difference. She's got night pain. So she's on big doses of paracetamol and NSAIDs. I changed her away from Panadol Osteo to more regular Panadol because it makes more pharmacological sense, and it wasn't enough. So the question is, what do you do next? Would you use an opioid in this person, and what would you like to know before if you started? So, Cameron, would you use an opioid in this person?
So, I mean, some of it depends a lot on how close we are to getting her some sort of definitive treatment.
Okay, so if the surgery was 5 years away?
No.
If the surgery was 3 months away?
Maybe.
Yeah, okay. So I would take 3 to 6 months. I would go, okay, no previous history of any problems. I would be saying yes, maybe some low-dose opioids at night for her pain. But more importantly, maybe a very low dose to get her in the pool, to get her to do some stuff.
So I think that's a key point, though, isn't it? This isn't just about medication. Medication is that end of the management plan stuff. It is everything else in between. It's the exercise and the hydrotherapy and the physiotherapy and all the other stuff and the intra-articular steroids, maybe if that was going to work or not. That comes as a discussion well before you're handing over a prescription, because that means you're talking about someone's function and you're talking about that rather than medication. So that control of their health at that point is actually things that they can do inside them rather than positioned outside of their body in a box of pills.
Yes. Okay, so we'll have to zoom a bit.
Yeah.
Okay, we're talking about now risk reduction strategies for different groups, all of those groups. So for post-surgical pain, this is a list of the estimated incidence of chronic pain and chronic severe pain from various sorts of surgery, which is interesting. But
so, Rick, just on that list, is there any one of those that really stands out to you
as being
unusual?
Oh, vasectomy. Yeah. What does that mean? So this was very interesting. This is a study where they looked at, this is a North American study, where they looked at whether you gave people opioids or not post-surgically for a vasectomy, which seems strange to me that you ever would, but they did. And basically it says that if you do, the number of people who are continuing to use opioids at 90 days is between 6 and 10% of the patients.
I've never had that experience.
So if you're going to use opioids in post-surgically, it needs to be a trial and there needs to be an end date. And there needs to be a lot of discussion with the patients about the dangers of prolonged use and the likelihood if they do have prolonged use. And this is, I think, is the most critical thing you can say. If we give you this stuff for a long time, almost certainly you will wind up with more pain than you started with. You may get opioid hyperalgesia, you will develop tolerance, and there's a significant risk of you winding up with more pain than when you started. Now, I've found when I've run that line with people, they are reluctant to start. And I'm also absolutely amazed that once you start talking like this, when you try to do opioid reduction, patients don't struggle as much as the sort of the perception is it's going to be a really hard thing to get people off opioids. It's not that hard. And particularly if they're on big doses, so say they're on 200 milligrams morphine equivalent, you can go to 100 and nothing happens.
Because their receptors are washed.
That's
their
right.
receptors are washed.
Yeah.
I mean, I think it is important. So the points there are that every opioid prescription is a trial. Anyone on opiates has that dose on that prescription repeatedly challenged. It's never a set and forget.
That's right. So even in end-of-life pain with people with cancer and renal things, sure, opioids are valuable drugs and should be used. But I've seen a lot of people who've come to see me with malignancy everybody, including the patient and the surgeons, and have assumed that the pain they've got in their back is due to the malignancy, and that's fair enough. But with a bit of working out, you can sometimes work out that it isn't. It's their 20-year mechanical back pain and they're deconditioned, so they've got more pain. So you can actually do a lot for people, and because cancer so frequently now is becoming a more chronic illness, with better prognosis for so many cancers, you have to be a bit cautious about throwing them around early. I think you can do quite a bit of harm.
So there is a difference. We need to separate. There is a difference. End of life is not automatically equivalent to palliative care anymore.
No.
You can actually be somebody with cancer for some many years before it becomes
really
before it becomes an end of life issue. When opiates are perfectly reasonable because somebody doesn't have very long to live.
Yeah, and they're useful and
they do something and
they're very effective. But if you've had them on it for 3 years, you haven't got much left. So for back and other musculoskeletal pain, for acute pain, how do you decide whether you're going to give someone opioids for acute back pain?
They don't form the majority of what I'm saying. That's the first thing to them. It is all about keeping moving. It's all about exercises that can help reduce their pain. It's all about trying to work out what the diagnosis is and what's actually going on. And medication comes far down the track.
Sure. So my view about opioids and back pain, for acute back pain, is if the person can do something or move into a position where they can relieve their pain, they don't get opioids. If they can't absolutely get away from it, then opioids for a couple of days to allow them to move.
Yeah.
But days, not weeks to months.
Never set and forget.
No. And for chronic low back pain, the emphasis has to be on the basics, on strength, fitness, mobility, stretching, life, and occasionally in those groups.
So this is about that. There was a move from the US Pain College Society or whatever they were called, Pain Society, to change the thinking around opioids, so that what you did is you prescribed a small amount of opioids before a provoking activity. So somebody had something just before physio or just before hydro or just before something that was going to cause them discomfort, rather than just having this background stuff. And there is something compelling about that argument, but I would qualify it now, some years down the track, to say for selected people, because it certainly reduces dramatically the amount of opioids somebody is receiving.
Yeah, but if someone has an underlying opioid addiction problem, it's a strategy that doesn't work.
Oh, it leads to chaos.
With arthritic pain, these are basic messages. Moving does not increase joint wear. Maybe heavy weight bearing movement, but not all movement. And runners with OA knee don't have to stop running. They can run, but they may need some help with their changing their gait.
I'm just going to say, guys, we have lots of
So
just have to make sure we leave ourselves enough time for them.
Okay.
So we wanted to make 2 points. One is that every GP in Victoria is able to prescribe Suboxone. If we can go back one slide, Rick. there is videos and information and checklists available on the department's website. And the one thing that I would say is that we can do a lot more harm with prescriptions that we use every single day. Suboxone in its own right is actually a pretty safe medication. And I think we should be stepping into this space. And if you find that it's not that hard, being an opiate replacement therapy prescriber can also add a tremendous amount to the care of your patients.
Yeah.
Did you want to do this?
Yeah, naloxone saves lives. If anybody's on 50 milligrams equivalent of morphine a day, they should have naloxone at home. And you can get it from chemists.
Intranasal spray.
Intranasal spray. Barwon Health provide it to several pharmacies around this area, and you should use it.
And think about how a discussion around the need for naloxone and what it does and why you're suggesting it for people on more than 50 milligrams of morphine equivalent can help change the thinking in both ourselves and our patients as to what the role of opiates is in care. There's your homework tonight.
There's a good chart. And this is the take-home message, that use the term move it to lube it rather than move it or lose it. I don't like hearing the term degenerative changes on x-rays, or I think age-appropriate changes. And every opioid is a trial. And naloxone, as we said, never set and forget. And any reduction is worthwhile. So if you get someone down a little bit and a little bit and a little bit, it's all increasing safety. Okay, questions?
Now, unfortunately, we can't see this.
No, I will read the questions out. Thank you so much, guys. I think it's fantastic conversation with two very experienced GPs on a very difficult problem. So our first question is from Anonymous. Pain clinic issues. How often are patients discharged on what would seem to be unsafe opioid regimens? What to do?
Thanks for putting us in the pool.
The first thing that I would say is that the pain clinic
is not what it was.
in Geelong would say that the vast majority of patients arrive to them on opiates, which, to be honest, is probably why they've ended up at a pain clinic. But I actually think the pain service in 2021 is not the pain service in 2010. What would you say, Rick?
Absolutely different. And there's now there's two parts to it. One is that they're moving away from opioids and their rules about prescribing them have tightened up. And they've also accepted that addiction is a real thing.
I mean, look, the other thing is that you saw one of those case studies. One of those case studies was from a major pain clinic. And just because one of our specialist colleagues makes a suggestion, we are not their community interns and we're not their community residents. So if somebody comes back with a suggestion that I think is bonkers, I'm under no obligation to do it. And I'm under every obligation to present my opinion, even if it differs from one of my specialist colleagues. That doesn't mean that I don't like them, I don't use them, I don't value them, because I actually do. It just means that sometimes I disagree, like I disagree with people I work with all the time. I think I disagree with Rick every second day about something that he's doing medically. But that doesn't, and I think that's the sort of thinking that we need. It is actually okay just to go, yeah, sure, the pain clinic said that, I disagree. This is what I think we should be doing.
Next question is, great presentation, Zig and Zag. And that got a lot of likes. I was thinking grumpy old man, but sorry about that.
Piss off.
Paul Egan asked how quick to get rid of the benzos, which has come up in a few other questions too.
Okay.
In that case.
Right. Yep. Well, you can go, first of all, if
it's institutional, so there's two bits here.
Yes.
One bit is if they're in an institutional closed setting, you can actually do it really quickly. The actual risks of seizures in the reduction of benzos is actually really rare. I used to do this in prisons all the time. I think in 14 years, there may have been one person that had a seizure as their benzos came off, and I'm still not sure that was related to the benzo reduction. So when we're thinking about that as the story, let's just put that into perspective. The second bit is if you're doing it in the community.
In the community, you have to develop a relationship with the patient. and you have to be enthusiastic about the benefits. And if you are, I've done this dozens and dozens of time with people, and I sort of, the time, say someone's on 40 milligrams of diazepam a day, my expectation is that we could easily get them down to 0 in 6 months. Easily.
So there's a couple of principles. Turning Point have got some really good guidelines on this. They talk about, and I agree with them, you convert all of the benzodiazepines to one, and that's diazepam.
Yep.
And then you take 10% of that dose off every fortnight in a one-way wean to 0.
And that's the most important thing, is that when you do this process with agreement with the patient, you say, this is a one-way ratchet. It only goes down. It can slow, but it can't stop.
The biggest risk is that they run.
Yeah. So if you do it too fast, they run away and go and see someone else. But mostly they don't. I think if you show enthusiasm and you project that this is for their benefit, most people are, and they're so much better when they get off.
3 months after you've stopped benzodiazepines, your head is clearer and you are thinking better than you did when you were on benzodiazepines. It's sometimes valuable, if there's a significant other that you can recruit into this,
yes,
to take a short video of what they're like, because they will be shocked.
Yes.
And I've done that
Me
in
too.
the past a number of times, and the patients will recognise how much clearer they think 3 months after they've stopped.
The other thing about the benzos is, if you have someone who is struggling a bit, one of the phrases I use is benzodiazepines, particularly at high chronic doses, turn nice people into dickheads. And they're so used to their families and their friends calling them that, they might think, oh my goodness, yes, there is some validity in this, and you can do it.
Yeah.
It isn't that hard to do. I see them, if I'm doing it, I see them twice weekly, and that is a very valuable use of your time to do that.
I think it's actually easier than reducing opiates, personally.
Yeah.
I'll keep going because we've got lots.
Yeah,
And Laurie Cameron, and this is a hard one to answer quickly, I think. I'd love to try and reduce opioid dosing used by one of my patients who is on massive amounts long term, as prescribed by her pain specialist. Any suggestions of how to go about addressing this? So I think it's more, how do we start the conversation, maybe, I think.
The first thing I would say is to sow the seed, if he's on it for pain, clearly, is to sow 2 seeds. One is the seed that you will wind up worse than you started. Everybody, he's been on opioids on massive doses for a long time. He is now worse than he would have been if he hadn't been. And if you continue, you are going to get more pain, not less. If you increase the dose, so you double the dose, say he's on 100 milligrams of morphine equivalent, and you double it to 200, he will get a small reduction in pain, maybe 10% for a week, and then he'll be back to where he was. If he went from 100 down to 50, not much would happen if it was done in a controlled way, and he would then be, his other pains would be better. So the fact is, people on high doses do worse in terms of pain, and they can be reduced. The other message is that the pain isn't due to damage. It's not due to ongoing damage. So hours of discussion about pain pathways, and the fact that his pain does not mean further damage is occurring in his back or his leg. It's pain pathways that have been established, and opioids make the pain pathways better established and worsen the pain.
So it's engage.
Yeah.
But also you need to think about your obligations. If you have any reasonable suspicion that that person is getting dependent upon opioids, they need a notification, and that is a consequential decision as to how you're going to act. And it is reasonable to start talking about that. I've done this, where I've suggested that there may be some dependency issues, demonstrate it and said, now we have to change. And that's often helps that patient move a bit.
The more subtle ones are the ones that are on moderately big doses, show no other dependent behaviour. They're working well, they're doing all these things, and they come in for their script every few weeks, and if you say to someone like that, well, why don't you got TAC, for instance, so they'll fund you going to Keezer, which is a rehab gym, expensive rehab gym. And they say, oh, no, I don't want to go. So that signals that you're offering them something that will reduce their pain way more than any opioid, and they're choosing not to take it. What does that signal to us? Clearly, there's a big problem, and almost certainly a dependence or addiction problem. And there's another question to ask is, do you ever take it to relieve other distress? And if someone says, oh, I had a fight with my wife, so I took a OxyContin, then you know there's a huge problem.
30% of people took a tablet of containing codeine for a reason other than pain in the years before that it was rescheduled. And I think it was Laurie Cameron that asked it, wasn't it? So
yes,
we're always happy to help you out if you want to contact us, Laurie.
Yeah. Yeah, I think it's in terms of this particular question, I actually think it's a whole session, you know, the conversation. It's the biggest part, and I almost think we need to earmark it because there's so much interest in this. And I think as GPs, we're struggling with a lot of this, and we know it. We just don't know how to get people started. I think once we start the process. Yeah. But more questions I want to keep because we'll go a little bit over time, but we'll only go 5 minutes.
We'll try and answer these quickly too. Sorry.
Yes. Charlie Cork just says, fabulous session. Thank you so much. Anonymous says, yep, need to be end date for endone post A&E. The vasectomy case was really insightful. So that's more a comment, I think. Anonymous, please don't all forget the highly tempting and I would suggest under-recognised issue of opioid diversions, which is patients selling opioids. I'll take that as a comment, I think. And he's all set for a cocktail party.
I suggest one of the cocktail components that really worries me is pregabalin.
Yeah.
All right. So if you have someone on 300 milligrams of pregabalin and they want more, they have a substance problem. Absolutely. It is the most over-prescribed and overused crazy drug in our culture. I just can't.
If you want an insight into it, there's a set of articles from Dublin that are titled Lyrica Nights. There's also a BBC Drugs in England or Drugs in Scotland series where they follow two people going around to various clinics scamming pregabalin to use. It's given the name of Budweiser on the streets because if you've had some opiates with it and you take it, you get a bit of a beer buzz, reportedly, and particularly if you are a bit creative in how you administer it. People are very creative in working out which way works the best, and certain parts of the community have worked out that if you actually insert it rectally, you get a much stronger beer buzz.
It's also been found in serological urine drug screening
in Sweden.
What I can't remember.
1 in 8.
1 in 8 people who on the street who had drug problems had non-prescribed pregabalin on board. It's just
1
crazy.
in 8. It's huge.
And it's. I don't know if you've ever prescribed it for the elderly with someone who's got zoster, and you give them a small dose and they fall over, and it is a crazily overused drug.
Do you feel the same? Gabapentin?
Gabapentin has a similar substance misuse impact, but not as much.
Not as much.
So in the UK, I actually think both of them have been classified as Schedule C. Is it Schedule C in the UK? Schedule C substances. But it's pregabalin is the one that predominates amongst the people who use drugs.
So if the concentration of the consultation and the discussion with the patient, the drug bit needs to be tiny. The activity bit, the lifestyle bit, anything else needs to be massive. If the PHN wants to do anything about this, one of the biggest things that they could do is there used to be a program where GPs could prescribe to all sorts of places like the swimming pools, and the PHN negotiated huge discount for people with pain. So you didn't just have to say, well, you need to exercise. You could say, here, with this place you can go, there's an exercise physiologist. It didn't cost an arm and a leg, and it was fantastic, but it was disbanded once it was found to be working well.
So that's about substituting.
Mm.
So you've taken something that somebody relies on away from them, but you've given them something in return that they can rely on. And it actually does work. That scheme, I mean, I had a number of people that I got off opiates because I was able to replace gym with their drugs.
Mm.
Drugs with
drugs with a gym. I got it the wrong way. Yeah.
There are a lot more questions, but we are over 5 minutes, and I've been told that that's kind of the limit. And so I just think this is a conversation we need to keep having. So I really thank you guys and your experience. It's really valuable conversation. So today, that brings us to the end of today, and which is a fantastic day. Really thank all our speakers and the sponsors, and also all the hard work the PHN behind the scenes have done to create this conference. Please take the time to fill out your evaluation. It really helps us plan further events and make the day that it can be. So we'll see you again tomorrow at 9 o'clock. Have a good afternoon and evening.
Thank you.